As many of us know, there is a therapy for cancer known as immune checkpoint inhibitors that, in addition to treating cancer, can also cause new onset type 1 diabetes. And I've always been interested in this, partly because I don't really understand what's happening, and also because patients who develop this form of type 1 diabetes really have type 1 diabetes. There's no honeymoon period. They're often in DKA and they need to be treated really from the get go as people who are completely insulin deficient. There have been a number of recent case series discussing this type of diabetes, but I think there's still a lot that we don't know. Now, first of all, immune checkpoint inhibitors are different from conventional cancer treatments. We know that immune checkpoint inhibitors differ from conventional cancer treatments. I'm not an expert in this, but I do know that they function by releasing basically the brakes on the immune system, which then allows the immune system to specifically target and combat tumor cells, thus helping to treat the cancer. There are a number of different agents, and different agents cause different kinds of side effects. But the endocrine side effects include a disruption of the pituitary, autoimmune thyroid disease, adrenal disease, type 1 diabetes, and hypoparathyroidism. And again, it depends on the type of immune therapy as to what's the most common kind of endocrine disorder you will see. Type 1 diabetes most commonly occurs with anti-PD-1 or anti-PD-L1 antibody monotherapy. And so what happens is that within a few months to even up to a year or two after these therapies are initiated, patients will develop fulminant new onset type 1 diabetes. This often presents as DKA, probably in about half of the cases. And again, it's because they're so insulin deficient. And we don't actually know the rate of this occurring in patients who are treated with these agents. Some series say zero point 0.1 to 1.4%. Others say 8% of patients treated with these drugs. But suffice it to say, it's common enough so that I see it. Immune checkpoint inhibitor induced type 1 diabetes occurs in varying rates, but it ranges from 0.2% of people treated with these agents up to 8%. I think what's important is to be aware that it can happen and to monitor patients for signs and symptoms of DKA. There's nothing we can do to predict it, so measuring autoantibodies in advance doesn't help, or obtaining a family history. I think obtaining a baseline fasting glucose level in A1C can be useful just to follow patients and also to rule out pre-existing diabetes that wasn't otherwise diagnosed. We do think that there are specific HLA alleles that are associated with an increased risk, but that's not commonly measured in our patients before they begin these therapies. So, within a few weeks to a few months to even a year or two after starting an immune checkpoint inhibitor, patients may develop diabetes. And what's interesting about it is that in not everyone are there even positive islet autoantibodies after they've developed this form of autoimmune diabetes, or at least presumed autoimmune diabetes. Oddly, many people do not have positive islet autoantibodies who develop this kind of type 1 diabetes, and they do have very low levels of insulin and C-peptide, as though they have overwhelming beta cell failure. They often also don't have a very high A1C level at baseline because they haven't been having diabetes for a while. I think in a lot of these cases, it really is a very sudden onset, very severe form of type 1 diabetes, and they haven't been exposed to hyperglycemia for a long period of time. Now, to make matters even slightly more complicated, there are people on these agents who do develop a somewhat slower evolving form of diabetes that looks a little bit more like type 2. But I'm really talking about this more severe form of what seems to be sudden, new onset type 1 diabetes that requires insulin therapy for life. I try to make people's lives as simple as possible, particularly when they're dealing with cancer. And I'll start people on a multiple daily insulin injection regimen, but often it will end up being easier for them to manage their diabetes if they're on an automated insulin delivery system. And I tend to put them on a system with a pod, like the Omnipod 5 system, just because for many that's simpler than dealing with some of the more complicated systems. But really, I would review the pump systems with your patients to see if there's one that they feel that they could live with, basically, and handle. I put everybody on CGM, but I think that goes without saying. It makes all of this diabetes management easier. But I do treat this in the same way I treat type 1 diabetes in general, except it really isn't LADA. It's adult onset type 1, but adult onset type 1 without much residual insulin secretion that needs to be treated very intensely, really from the beginning. And again, quality of life is very important. So I spend a lot of time working with patients and trying to help them achieve the kind of control that's reasonable, as well as handling this new disease that they got on top of having their cancer treated. And as one very bright 13-year-old told me, "Don't you think people would rather have type 1 diabetes than cancer?" And I said, "Yes, probably it's best to treat the cancer." So, I think these are great drugs for cancer, and they just need to be agents that we're aware of in terms of their ability to cause diabetes. This has been Dr. Ann Peters for Medscape. Thank you.